The discussion for today is learning to love CMS audits. And I must say I've had the pleasure of hearing this presentation, so you are definitely in for a treat. I would like to welcome our guest presenter for today's webinar, Seth Avery. Seth has over 25 years of experience as a healthcare executive, serving as an auditor, consultant, administrator, and CFO. He has been certified by the American Academy of Professional Coders as a CPC. He has a BS from Campbell University and an MA from University of New Mexico and a Juris Doctor from Texas A&M University. Seth is a 14-year veteran of the U.S. military. Thank you so much for your service. And he is a frequent speaker at HFMA conferences and presents webinars providing education on various healthcare finance topics. So, without further delay, I'll hand the call over to today's guest presenter. Seth, please go ahead.
Hey, thank you very much, and I appreciate everybody taking some time out from a busy schedule. In this presentation, and I've done this a number of times, and I always try to update it, keep it current, add a few things here and there. So please, we look forward to your comments, and please, as we go along, also, if a question pops up, type it in. If we address it, that's great. We'll make sure we address it by the end. If not, we'll get to it in the Q&A session and do it then. And we're going to cover kind of a wide spectrum of CMS edit issues, questions, and just some of the versatility and challenges of using both the electronic data sets for submitting claims, editing them, reviewing them, and also getting your payments back, and how the responses work, how we queue up our staff, and how we keep current with all these complex issues. It's I try to draw in people a little bit with the title because I don't think it's actually possible to learn to love CMS edits, but we certainly can endeavor to understand a little bit about what CMS and the Medicare administrative contractors are trying to accomplish, how we can conform to that, and how we can get a little bit better results. And one of the things that I'm going to try to do as I go through here is, in the presentation, when you download it, I have tried to put as many links to the source material as possible because I think that's very important. It's that whole thing of, giving you a fish versus teaching you to fish. I'd rather you could go out, find the source material, use that, investigate it, understand it, and then you're much better off for the experience. If any of my links don't work or they're not what you expect, certainly follow up with me, and people have done that in the past, and we can always improve the presentation. So a little bit of, that was my introduction. We're going to start out with talking about National Correct Coding Initiative, NCCI edits. We're going to talk a little bit about OCE, which is the Outpatient Code Editor, MCE, which is the Medicare Code Editor, 837 standards, and cover a few things that for some of you, this just may be old stuff that you absolutely know and you can nail, and for people a little bit newer to this field, they may not, it may be just new material, so bear with me. Okay, so getting into, let's talk about NCCI. So in your resident billing systems, you will typically have edits for NCCI, OCE, and MCE built in there. And when you go to post either charge batches or complete claims, or if you're doing direct data entry or DDE into the Medicare FIS system, you will get these OCE and MCE edits back, which you'll see how that plays in with NCCI in a moment if you're not familiar. But really what I have found over the years and years of doing this, and actually if you listen to my bio, what my bio told you is what my wife would say is that I have some sort of ADD because I had all these different jobs over the years. But I did settle down. I started this company 14 years ago, so I have been fairly consistent with that. But as I've looked at this over the years, what I have found is you will find on occasion, I don't say it's typical, But where I see people have problems with these edits is they don't understand what they're trying to accomplish, and they don't know how to really correctly fix the claim or the charge appropriately to clear the edit. So I used to call it, back when I worked in the hospitals, I would get this kind of heavy right thumb, as I called it, and people would end up doing adjustments instead of fixing. So they would take the charges out instead of understanding what they could do to make them correct. Okay, so this corrective action can certainly include such things as review of a clinical record to see what service was actually performed, and removal. That may lead to a removal of a service, an addition of a modifier, and other changes. So many of you today in your health systems are putting in revenue integrity functions, and a lot of this may be more directed by revenue integrity. They may be overseeing this, and they may be gleaning this. But a lot of these edits you're going to find require somebody who has the access to the actual clinical record for the services performed and can understand and decipher that clinical record. So that can't be undervalued in this. Just a little story about this, so bear with me for a second. I'll try to keep your attention here. But I remember going into a new health system I was working at, and a lot of people in the billing area, and I'm putting like fingers up like quote unquote billing area, because the billing area is actually a long process in the revenue cycle. But these quote unquote billers had CPT manuals, and they were using the CPT manuals to correct claims. And I thought, well, how are they doing that if they don't even have access to the clinical record to see what's actually performed? So that's just a little, you may not see much of that today, but those are little things to think about. Okay, so NCCI, National Correct Coding Initiative. It is based on CPT, which is current procedural terminology, or level 1 for HCPCS, and you're probably all familiar with CPT. I'm sure at the minimum you can spell it. And then it's also, there are groups of professionals, national societies, policy participants in basically building this NCCI edits, and it all rolls into one CMS contractor that developed them initially and maintains them quarter to quarter. And again, as you have questions, you can always fire them off as we go through this. So NCCI started, I believe, October 1st, 1996. It was rolled out with the physicians. The following year, in 1997, it was rolled out to hospitals. And then in 2007, the medically unlikely events, or MUEs, as you've grown to love them, were added in 2007. And they were, and a lot of people don't realize that's part of the NCC edit program, but essentially they're maintained by the same contractor, as I understand, and they're published quarterly in the same, you go to the same site to get them. There are 3 components to NCCI. So there are the column 1, column 2. Medicare changed them to column 1, column 2 in like 2002, 2003. They used to be called comprehensive and component. Now, comprehensive and component were actually descriptive terms that led to understanding what the edit was about. So CMS, of course, changed it to column 1 and column 2, but we're going to go through some examples of that. And then they have the mutually exclusive, which means these things don't belong together, and MUE, so we just talked about. The first 2 are what we call procedure to procedure. They're comparing a pair of HCPCS or CPTs. And of course, you have to put PTP because this would not be a good Medicare discussion without a lot of acronyms. So as we can see, we got 3 acronyms on this page, so we're off to a good start with our acronym count. Okay. Now, we're going to kick in a question here. I use questions in my presentations. This was a little bit harder presentation to develop questions, but the idea here is to try to keep attention, keep people participating, paying attention. So the question is, and some of you may not know at all what we're talking about here with the 59 modifier, but it's just a question to get you thinking. When would we use a 59 modifier? And you got some answers here, and while we're waiting for everyone to submit their answers, just go through. And basically, the choice, when a service was performed on a separate site, when a service performed in a separate session, when there's a modifier status of 1, and when you want to get paid. Now, the joke was years ago, the answer always would have been when you want to get paid, but we'll see how everybody does and what you think about it. And if you don't know what the 59 modifier is and how it's used, don't worry, we're going to cover that. This is kind of a little bit of an icebreaker in a webinar.
Awesome. Well, it looks like we have about 60% of the votes in, so get last minute and we'll share the aggregate results so you can see how you're positioned. All right, so we have crept up to 70, close that out, and those are your results.
Okay, so when a service was performed was the number 1 answer in a separate site. And I think that got cut off, but basically it said no anatomical modifier, but we'll cover that in a second. Separate session was number 2, modifier status of 1. Again, we'll cover that if you don't know what the heck we're talking about. And then when you want to get paid, and then all of the above. And really, it's kind of a trick question because all 4 above are the right answer under the right circumstances. So we're going to go through that and talk about when you were going to use the 59 modifier. So don't get too angry at me yet. Wait, save that hostility for later. But let's get to these edits, how they work, go through some examples, and you'll understand what I'm talking about. So these edits were developed to eliminate what they call bundle billing. So it requires the provider to build the most comprehensive service. So what the heck does that mean? So my example that I like to use, because I think it's very straightforward, and if you didn't notice from my bio, I'm an attorney and a CPA. So even though I trained as a coder, I struggle with clinical examples, and when you start to hear me pronounce clinical terms, you'll just cringe. So I try to keep with very simple clinical examples that everybody can work with. So let's say you have an accident where, let's say somebody's on a bicycle, they fall down onto the pavement, they rake up their back, they've got some wounds in their back, they go to the emergency department. And so we're doing wound repair. So we've got some wounds that need to be sutured, we've got some wounds that need to be debrided, and we've got combinations of the two. So in the NCCI edit, let me pop over one, and then maybe we'll go back and forth here. So bear with me. So we have this edit, and it's 12001, which I need to really think I need to add the CPT definition, but really this is a wound repair and a wound debridement. And if you think about it, when you're doing a wound repair, suturing the wound, you would debride it if necessary. So the edit looks at it and says, hey, if you're doing a wound repair and you're doing a debridement, that's really, the debridement's part of the wound repair. So the NCCI edit says, hey, only bill me for the wound repair. Don't bill me for both. But what if the debridement was on a separate wound? Then we're going to need to consider how we're going to communicate that to CMS so that they appropriately edit the claim. Okay, so when we look at our modifier status, and again, I'm going to show you an example of this as we go forward. Every pair edit in NCCI will indicate whether it's a 0 or a 1. 0 means that I don't care what the clinical circumstances are, you can't disable this edit. And I'll talk some examples of that. A 1 indicates that an approved modifier will disable an edit. So, and just giving you a little screenshot, you can actually go, because I do this occasionally as I update it. Sometimes when I'm trying to analyze a particular situation on a record integrity issue, I'll just go out and pull the actual NCCI edits, and they're available online at CMS in Excel format. But you can see here, you have the first column, which is the comprehensive procedure. The second is the component, and then it tells you in the 1, 2, 3, 4, 6 column over, it either gives you a 1 or a 0. 0, modifier is not allowed. 1, it's allowed. 9, it doesn't apply. And then you always need to look for a deletion date because these edits are actually deleted as they go along. So let me go back again. So in our case of the 1142042, we see a modifier status of 1, and then the rationale for the procedure to procedure edit is more extensive procedure. So in this case, what it's saying is, hey, the 12002, which is the debridement, actually I think I used a 12201 in my example, which that number just actually tells you how large the wound is, but from an edit standpoint, it gets you the same result. So it says, hey, that wound repair includes debridement, so unless you got another reason, don't bill it separately. I'm going to edit it out. So if you put this through your claim scrubber and then ultimately on a bill with a 12001, a 11042, without a qualified modifier, you're going to get a OCE edit, outpatient code editor, which we're going to talk about in a few minutes. So when would we use the modifier to disable the edit? And if the answer is to get paid, we need to back up and say, well, what's the clinical example? So in an example where I have 2 wounds on the back, so it's the trunk of the body, and I have one wound that I suture, debride and suture, and one that I just debride, I'm going to have to tell CMS that there's actually 2 separate wounds and that it is appropriate for me to bill this debridement code. So to do that, I don't have an anatomical modifier. Anatomical modifiers are things like LT for left, RT for right, F1 through 9, 0 through 9 for fingers, T0 through 9 for toes. Hopefully I'm getting that right. You have eyelids, etc. Those are left, right, toes, fingers, eyelids. I'm sure I'm missing something that are anatomical modifiers. But your trunk, you don't have a left or right. You don't have a 0 through 9. So in that case, you don't have an appropriate anatomical modifier. So in this case, we would append a 59. And it would be appropriate, it would go through, and as long as our clinical documentation upon review supported that, we would get paid. Okay, so that is, and again, this is a little background on it, but that's how the 59 is used. 59 is used, and I'm going to show you there's a couple other codes they've added over the years, the last 2 years, to give a little bit more explanation. But again, it's where there's not an applicable modifier. And again, if you're not coders and you're not here doing this work, this is really for you to understand in the revenue cycle process why you're getting those OCE edits or from other payers on National Correct Coding Initiative. So if you look in your CPT manual or your encoder, it'll give you a list of modifiers approved for ambulatory surgery and hospital outpatient. If you're in a professional setting, there's a very similar but slightly different list also available in that manual. And just a little background here, in 2015, there were $11 billion charges in lines billed with the 59 modifier to Medicare with a projected error of $450 million. So here's the lesson. See, I even put lesson. I should like bold it, maybe draw arrows on it or something. Here's the lesson. The lesson is don't use the 59 if there's another appropriate clinical modifier, or if the modifier status is 0, or of course the clinical example doesn't support the use. But if there's a modifier standard of 0, you can put whatever the heck edit you want on it, but it's not going to pay for the component procedure, the column 2 procedure. Okay, and again, I gave you a link here, a little bit more information. They added essentially 4 additional modifiers to give more explanation. The 59 is still valid, but you can use XC for separate encounter, XS for different organ structure or location. If you end up having a different practitioner doing it, you can use an XP. And again, XU, somebody gave me a good clinical example one time, but it escapes me. Unusual non-overlapping service The use of service is distinct because it's not overlap the usual components of the main service. But those are additional valid modifiers for your coders to use when you have a component service that meets one of these definitions and you have a modifier status of 0. And you can follow the link here. And again, if you have any problems with the links, please let me know. Okay. All right. I'm going to move on. If you have questions, please send them to me. Okay. OCE. OCE is Medicare's outpatient code editor, which is their comprehensive code edit. So it applies both to OPPS, Outpatient Prospective Payment System, and non-OPPS facilities. And it indicates an individual error by each claim using a numbering system. And I'm sorry, I did not get the latest edit error. There's actually 107 or 108. So that's my error there. That slide should say 107 or 108. But you can find the edits here. And what I generally do to try to figure these out is I go into, there's a document that I think you can find from this link, but it's going to go through actually the whole OCE program and each of the blocks, each of the edits, how the schematic works, etc. And occasionally when you find a problem with a claim and you can't figure it out, that might be useful, depending on how far down that rabbit hole you want to go. But you get, and I would say each edit in that list is going to give you the result of that edit. So, and I won't say all of them do, most of them indicate the impact of the edit. RTP is, the entire claim is rejected, and LIR is line item rejection. The claim goes through, but that single line item is rejected in the OCE edit. And again, most of you in the hospital world should have an OCE editor resident so that when you post charges to your system and that charge batch goes through, you should get your OC edits and you should be able to correct them before they go out. So we're going to go through and we're going to talk about a few, let me back up a little bit to the OCE here. And in your encoder, it's also going to show your edits. So we were just talking about NCCI. So when you get a code edit like 39 and 40, those are actually NCCI edits in your OCE. Man, that's a lot of letters, I know, but bear with me. But here's another one that pops up, which is always interesting, is the OCE edit for 18. 18 is a status indicator C code on an outpatient claim. Because again, OCE, it's all outpatient claims, right? So if you bill, for those of you who don't know what status indicator C is, for Medicare, that is inpatient only. So if you put a CPT or HCPCS on an outpatient claim that is a status indicator C, you'll get a RTP, I believe it's RTP, with a OCE edit of 18, which is telling you, hey, Medicare considers that an inpatient only. And quite often, what's driving that is that you have a failed admission for whatever reason, and you're billing a true inpatient claim as an outpatient, and then it's hitting that edit. So again, if you go to that list that I gave you the link on, there are plenty of examples for you to look at each of those edits, and if you have questions, please send them through. But as you look at, let me back up a second. As you look at that list, your process with your staff for clearing those edits is driven by understanding the reason for each one of those edits. So, for example, if it's an NCCI edit for a component being billed with a comprehensive procedure, and it's a status, you have to look at one. You'd have a little flow chart in your brain. So the status, is it a modifier status is 0? Okay, so I just have to take the component off. I can't do anything with it. If it's a modifier status of 1, then I need to look at the clinical record and see if there's any clinical reason that I can append an appropriate modifier to get paid for the component procedure. So that type of rationale, that kind of thinking is driven by those OCE edits and their numbers. Okay. MCE, Medicare Code Editor. This is the inpatient. It's very simple. For those of you who have been around a long time, in 1983, Medicare moved from a cost-based system to a DRG-based system. And those DRGs came in 1986 with a set of edits called the MCE. And again, they're fairly basic edits. They're nothing as sophisticated as the OCE. But it's going to look at what we call code edits, which are going to look at how a diagnosis, now it would be ICD-10 procedure and diagnosis codes, and see how they work in relationship to the patient's age, sex, diagnosis, and procedures. So if you have a procedure that would only be done on a male, but the claim indicates female, if the procedure is incompatible with the patient's age, or things like that, it will indicate those. Again, they're not overly complex. They're a fairly simple set of code edits. Coverage edits, again, is going to look at a fairly limited set of things that whether those procedures or diagnosis are covered by Medicare. And quite often, I think those would be things that would indicate whether this potentially could be like a workplace or injury-driven diagnosis that may be covered outside of that. And then clinical edits, it looks at just, again, the consistency of diagnostic procedure information and see if it, somewhat in a very loose sort of way, kind of like our local coverage determinations, but not even that elaborate. So I don't know how many times you guys have looked at MCE, but MCE needs to work basically the same thing that you need to group a DRG: age, sex, discharge status, diagnosis, procedure codes, and discharge date. Because all of those drive different pieces of the edit, and for those of you who have gone through and understand how the grouper works, how it drives the MSDRG grouper. And again, there's a reference, and it does walk through these areas. Okay, now just to make sure everyone is awake, I'm going to throw you out a question here. Is there a different claim format for inpatient and outpatient claims? And again, if you're not familiar with this, don't feel bad. Take your best guess. We don't even have the ability to embarrass you if we wanted to. So look at that. You got a 50-50 shot at getting it right.
Awesome. The odds are in their favor, or at least not against their favor. And right now we are right at about 65% of the votes in. So last chance, folks. I'm going to shut it down in 3, 2, 1. And let's look at these results.
Okay. So we have 61% saying yes, there's a different format for inpatient and outpatient claims, and 39% saying no. So what's the correct answer? So the correct answer is inpatient and outpatient claims are actually in the same format. There may be slightly different requirements within the standard, but they're the same. The big break is between institutional and professional. So you'll quite often hear referred to as the 837I and the 837P, of which 5010 is our current standard. I put a link to if you're not familiar with the ANSI 837 standard, there's a nice document that I put a link here to, which will kind of walk you through it. So again, if you're not familiar with it or you want to refresh, take a look at that. Again, if somebody's got a better reference or a nicer format or document to look at, please send it. We'd be happy to always share better educational tools as we go through. So the big difference in the 5010, for those of you who went through the conversion to 5010, I think it was like, what was it, 12, 13? 5010 gave us the ability to, amongst other things, add attachments to our electronic claim. And there are a number of payers and providers, such as in the state of Florida. Blue's taken a great initiative with this on using attachments. So if you need to send an op report, you can just send it with the initial claim. If you know Blue Cross is going to need for bariatric surgery an operative report or an H&P or whatever, then you can submit it using that standard. So it's just a little extra there for you. A couple of things I wanted to cover. Again, these aren't edit driven. They're more about how you can communicate information to CMS and how they're expecting you to communicate information to make it work for you. So some of the key components of the 837 or claim are condition codes, revenue codes, HCPCS, admission source, discharge status, patient status, and of course the ICD-10 codes. Charges are in there somewhere, but unless we're talking about outliers, charges are typically not that important. Other than, I know, cost reporting, all those things, but on the payment side of it, we're talking about here. Little known facts for you to know: in the ANSI 837 standard, many of the data sets are actually maintained by other entities. So the National Uniform Billing Committee, to those of us who know them well, it's NUMC. Actually, BC. I got a little typo there. How many times have I done this presentation? Didn't even notice that typo. But National Uniform Billing Committee, as an example, maintains and develops the standards for revenue codes. I know many of you wondered who decides on revenue codes, but it's in UBC. There are some nice documents. I put one out here for the Medicare Claims Processing Manual. You can go, and I give you the link here, on the internet-only manuals. These are all in PDF format. They work very well, but you can get the layout again of the standard. Okay, so now we're going to move on to another question. Again, trying to keep everyone focused here and ready to go. And the question is a description of the service or charge required on a claim? Again, you got a 50-50 chance here. If you're a Hunger Games fan, you'd say the odds are ever in your favor, I think is how the expression goes.
I think you're right, Seth. It looks like we are right at about 55% of the votes in, and so I will go ahead and wrap this up so we can see the results.
What that tells me is most people are still paying attention.
Yes, that's a very good indicator. You're right.
So is it required? So 55% said yes, and 45% said no. It's kind of an interesting thing that I've told people this over the years, and I think it shocks most people. Description is not a required field at all, and really never has been, going back to the UB 82, for those of you who are old enough. The description you typically use for your billing statements, because the patients want to see what they're paying for. The payers are ignoring it. They're using diagnosis codes, procedure codes, CPTs, charges, and other items on the claim to determine the payment. So it's not actually required. But again, it drives your statement, because what patient doesn't want OFF VS IV or office visit level 4? Yeah, because it means a lot to them. But that's generally what is driving your description process. Okay. So again, just a little showstopper there to keep you awake. A couple of things we're going to talk about on the 837 here. Condition codes. If you've not looked at that earlier link that I gave you, if you look at the condition codes, there are a number of condition codes that are critical to successfully getting paid from CMS and to indicate when you should not get paid from CMS. And I put a couple examples here. So 02 on a condition code indicates that the admission is employment related. So as you can understand, if it's employment related, CMS is going to look for some other form of payment, typically workers' comp, to step in and make that payment. But you're still reporting it to CMS. 07, for those of you who are running hospice programs, 07 treatment of non-terminal condition for hospice patients. For those of you who have not done hospice billing, it is a bit tricky to get hospice billing right, to get it to work. Generally, my experience, and maybe you guys are brilliant and have figured out all the hospice in and outs, but the man hours per hospice claim were generally one of my higher ones because, you know, you're just trying to make sure that you are working within the program and billing either for palliative or respite care only. So just examples. Occurrence codes are a little bit different, and you can tell by the name occurrence. So they're indicating dates within the claim. So a critical one would be like 25. So let's say Medicare was a secondary payer, but during the stay, or you have a or the course of treatment, you have a termination of a primary payer. The patient retires, patient decides to go Medicare only, so you would indicate that date with an occurrence code. And another example on the outpatient side is 29 would be when you would indicate when the outpatient plan for PTOT or speech was last reviewed or established or initiated. So again, understanding how condition codes work, how occurrence code works, they can help you navigate some of those denials that you're currently getting, and you're not understanding why you're not getting paid, but sometimes you're not getting the full range of information to the payer, which can be transmitted in both these condition and occurrence codes. And again, there's a full list in that reference. Okay, we're going to move on to hit a couple other topics here, which again are critical to successful navigation. Type of bill. For many people, this is a review, but type of bill indicates what type of facility is billing and the frequency of the bill. So for example, a 1 on the, okay, type of bill is really 4 digits, but the first one's a leading 0. All the ANSI standards love to have leading zeros. Your revenue codes have leading zeros. Your type of bill have leading zeros. I think they're just reserving themselves space for the next 1,000 years of doing this. But the second digit, technically, which you would always consider the first digit, would be 1 would be hospital. The next digit would be essentially what the bill classification is. So in this case, if it's inpatient Part A, it's going to be another 1. And then the frequency would be 1, admit through discharge, and that's typically your initial claim. So a 111 would be a hospital, inpatient Part A, initial claim or admit through discharge. Now, you can see, for those who are familiar, and again, you can look at this reference I gave you that lists all of these, and you can go through and understand them. But it's kind of a clever system because on the outpatient side, so you'd have a 1 for a hospital, a 3 for a hospital outpatient, and then the next one, you can use a 1 for an initial, but they've actually got, for those of you who use it, for ongoing services like physical therapy or maybe chemotherapy or radiation therapy, something that you need to indicate a series, you can actually use that last digit to indicate that. So if you put a 2 in there, it's the initial claim for basically a serial or a series bill, ongoing bill. And then a 3 would be an interim one, which means I've already sent you a 2, I'm sending you a 3, I'm not done yet, but here's the update to our bill. And then the 4 would tell them it's the final bill in a series of bill. So again, they're kind of clever. You're all familiar with the 5 on that last digit, which is a late charge. A 7, which is a void and replace. So it says, ignore everything I sent you before and use this one. And then if you send an 8, that says void, let's start all over again, wipe everything out, and the next one I send you is going to be initial 1 again. So here's a key. If you are doing data mining in your claims warehouse, you need to understand these bill types so that you're not duplicating services. So if you have a 1, an 8, and a 1, you just want to take the last one because the 8 wiped out the first one. So I see this error a lot when people are pulling claims to try to do some analytics, is they're not understanding the relationship between all these bill types, and they end up getting more charges and more services than they actually perform. Just a little tip. Okay, a couple little things before we wrap up here. Point of origin is really where did the patient come from, and sometimes this really matters. So for example, in your observation patients, the code that you use and the rule that you use for observation depends on the point of origin. So whether you admitted the patient from the ER, from another facility, and they're either a direct admission from your facility or from the community, you need to understand that. It's also going to have added implications for your 3-day rule, which has to do with your emergency department rolling into your inpatient claim. That's a topic for another webinar. And correct billing of observation services. So understanding point of origin, or that that admission status, is very critical. And what I find is you should do some data mining on this, because I find the hospitals have sometimes not a complete understanding of the accuracy of how this code is assigned. And it certainly impacts you from a compliance and a payment standpoint. Similarly, discharge status. I've looked at this at hospitals before that have had very large error rates on this. And discharge status will impact a handful of your MS-DRG assignments, and it will certainly impact your DRG, your transfer DRG. So again, this is something where I've given you the reference here. You can go read about them. I'll understand them. Discharge status 20 is where we all end up. If you don't know what that one is, that's deceased. But again, that is going to make implications in your MS-DRG assignment, your transfer MS-DRG. And if you're currently not auditing these, taking these and pulling the sample, or looking at them through some sort of edit just to see the veracity of them, that's something you might want to think about, because these are also a point in which people get errors, take-backs, and compliance issues because they don't understand the implication fully of using the correct discharge status. Okay, a few more references I've thrown in here for you on the Medicare Claims Processing Manual. And I gave you a sample, and I realized that most of you guys are probably in Novitas, Noridian. So Noridian may be your Medicare administrative contractor, but again, it's using those billing guides, and actually Noridian has some really good info out there on appropriate use of drugs, infusion codes, all types of services out there. So always take advantage of your particular MAC billing guide. Okay, I have taken away 44 minutes of what is otherwise a perfectly enjoyable day. And I am open for questions. I haven't seen any yet, but that may be because either I'm doing such a great job that everybody's stunned and hasn't come up with a question yet, which is fine.
I will take that as a truth, but to add to it, I'm actually hiding them from you. I didn't want those balloons to pop up as you were presenting and get you distracted. But yeah, no, we have had a couple to come through, and one of the questions was around getting copies of the slides in replay. So if you missed that announcement, you can get access to the slides right now by expanding the handouts section, which is to the right of your screen, and click on that PDF icon, and it's all yours. And then the chapter will also follow up with a copy of the replay that you can either listen to again or share with your colleagues. All right, so this one came in fairly early in the presentation, so you may have covered it, but Lori wanted to know where she could find a list of acceptable modifiers for NCCI.
No, that's great. So again, I generally, if you have an encoder, it's listed in the encoder, and if you don't, your CPT, depending on which manual you use, if you use AMA, it's in the appendix, I think A in there, but it'll list them as ambulatory surgery center and hospital outpatient modifiers. I don't think the claims processing manual has a current list of acceptable modifiers, but I did give you a link in the presentation to some of those new ones, but I don't think it lists all of them in that same MedLearn article.
Oh, okay, great. Thanks for that. In fact, Blair chimed in that she likes the links. There was one that wasn't cooperating for her, the link to the OCE download. So we'll take a look at that, Blair, for
Yeah,
sure.
I'll look at that, and if I've got a better one, I will give it to Nikki, and she can get it out to everyone.
Awesome, awesome. All right. I think really those are the bulk of the questions. Some of them came in and then they went back out after you addressed them. So if anyone has any last minute questions, I'm going to just share some closing notes and give you some time to type those in. So as we're wrapping up, I would like to remind everyone about a HFMA Colorado chapter annual conference coming up April 11th through the 13th at Westminster Marriott. And you can find more information about that on their website at HCCA dash co, or is it co-hfma.com? Sorry about that, guys. And yeah, it looks like we have exhausted the questions. So as we approach the top of the hour, I mean, I do want to thank everyone for joining the call and pass it over to Seth in case you have any closing remarks or statements you'd like to make.
No, just please follow up if you have any questions, and if you have suggestions about things that were a waste of time you thought that we covered, or things we didn't cover, because this is an ongoing kind of living presentation that I probably do 10 times a year throughout the country to different regions, different states, etc. So yeah, please, I look forward to your suggestions.
Thank you. And in fact, when we wrap this up, you'll automatically be routed to an exit survey where you'll get that very same opportunity to let us know about this particular session as well as future sessions. If there are topics that you'd like to see covered, let us know and we'll happy to corral some thought leaders and get them on this platform. So thank you again to Seth Avery of AppRev. As always, a pleasure working with you and imparting such great information. And have a great afternoon, everyone.
Thank you.